Welcome back, ladies and gentlemen, to Battling and Beating Cancer on the Blog Talk Radio Network, CAN TV in Chicago, and to all of you joining us streaming live worldwide at chicagobloodcancer.org, roadtocure.org, and the Hope for Lymphoma Facebook page. Now, my wife Charlene tells me that nobody can clear out the room the way I can. And we delayed our broadcast for about 5 minutes because I succeeded and cleared out the entire room. So we are back here at Rush University Medical Center on World Lymphoma Awareness Day. We are about to start the afternoon session. We had a fabulous morning session with this roster of one leading lymphoma expert after another. And just when you think, well, can we do any better? Well, this afternoon is even going to be better because we're going to start looking forward into some of the more novel agents, some of the great therapies that are there now, and we'll talk about some of the things on the horizon. And so on World Lymphoma Awareness Day, we talked earlier about the importance of patients participating by raising money for research to put it in the hands of these doctors so they can come up with these treatments. But also, we need patients involved in advocacy because it's a lot of work and a lot of process to get great treatments that are formulated and working in studies to actually get them on market, to stay on market, and then not to be defunded or by government bureaucracy effectively taken off. So please engage. Let's help us, because by expanding the scope of therapies out there, many of us are alive today and many more will be alive in the future. So let's get ready for our second half of follicular lymphoma on the road to cure. Ladies and gentlemen, she's Superwoman, Dr. Stephanie Gregory.
All right, thank you, Scott. Thank you. We made it through the morning and lunch. And Janine, thank you for those exercises. We had a little yoga you guys didn't know about. I already introduced Dr. Stephen Schuster, so I'm not going to go through that again, except University of Pennsylvania, director of the lymphoma program, a wonderful teacher, and he's going to tell us about some of those novel therapies that may lead the road to cure, and he's been involved in many of those treatments himself. So please, Steve, welcome.
I'd like to thank Stephanie and the Rush University Cancer Center for the invitation, as well as the Chicago Blood Cancer Foundation and the Hope for Lymphoma group. It's a pleasure to be here. My job is to wake everybody up after lunch, okay? I think the yoga helped. We stretched our bodies. Now I'm going to ask you to stretch your mind, okay? Because the topic that we're going to talk about is emerging treatments for lymphoma, and these are exciting. I'm going to focus more on concepts than on data. I will show some data. I think there's only one Kaplan-Meier curve in the whole slide set, and that took a great deal of restraint. Do I have control of the slides from here? Let's see. Okay, wonderful, thank you. Okay. All right, so we're going to be talking about the same disease that we spoke about all morning and talk about new approaches to treatment. You've heard about chemotherapeutic approaches and you've heard about transplant approaches. We're going to talk about vaccine approaches. We're going to talk about a new chemotherapy very briefly because Dr. Rommel did the most spectacular job on this new agent, but people are still working to develop chemotherapy. The chemotherapy is a good thing. It has a bad reputation somehow, but I've cured many patients with chemotherapy, and on our list of new therapies, we will include that approach. Immunomodulatory drugs, in particular, we'll talk about Lenalidomide or Revlimid. We're going to talk about B-cell receptor kinase inhibitors, just remember kinase inhibitors, and monoclonal antibody derivatives, okay? So we're one step beyond Rituxan. Now, the reason radioimmunotherapy is not on this list, and the reason that Rituxan is not on this list, and the reason that monoclonal antibodies themselves are not on this list is I don't really consider them to be new therapies anymore, okay? And finally, everybody's anxious to hear about chimeric antigen receptor T-cells and how we can target the cellular arm of the immune system to treat cancer. So what you'll notice is that all of these approaches, with the exception of chemotherapy, are immunologic approaches. Okay, so I'm going to take you through a little bit of immunology and hope that you understand how we're using this approach to treat cancers of the immune system. So, okay, this is my vision of a B cell or a B-cell lymphoma cell. They share many of the same features. The malignant B cells and normal B cells have much the same surface markers. In fact, we can map the type of B-cell lymphoma you have by studying the constellation of proteins that are on the surface. Everybody knows CD20 because it's been targeted by Rituxan, it's been targeted by Zevalin and Bexar. It is a protein that's used to define and identify B cells in the laboratory, and now it's a target. CD19 is like CD20. It shows up first during B cell development, persists throughout B cell development, and even in post-germinal center and pre-germinal center cells where CD20 is less strongly expressed, CD19 is there. Okay, it's part of the B cell. It's a part of a B cell receptor signaling complex. We'll talk about that. There are on the surface immunoglobulin molecules. So SIGs are surface membrane immunoglobulins, surface antibodies. So these are proteins that are identical to the proteins this B cell will make when it grows up into a plasma cell and makes antibodies and puts the antibodies into the plasma to protect you from infections, et cetera. Many of you know what they are. Bexar and Rituxan are antibodies. Many of us learned about antibodies because of Rituxan. So I assume that everyone has a basic understanding, but I'm happy to go into it in a bit more detail. There are in these antibodies regions that are unique to a B cell population or clone, but not so. Although every B cell has CD19, every B cell has CD20, and every B cell has an antibody on its surface, the antibody has a region that is unique to the B cell and B cell clone. So if we target CD20 or CD19, we're going to kill all B cells, bad and good alike. If we target just a specific region of the immunoglobulin molecule that's unique to the cancer, then we're only going to target the cancer. Okay? Inside the cell, there's targets. So these are cell surface targets, exterior of the cell. These are on the membrane. Inside the cell, in the cytoplasm, there are targets that are part of a B cell receptor signaling complex. So you're going to start hearing a lot about a B cell receptor is the surface membrane immunoglobulin attached to intracellular proteins. So the complex, BCR complex, B cell receptor complex, is this immunoglobulin molecule attached to some signaling molecules. And these signaling molecules will, when the B cell receptor is engaged or stimulated, okay, will turn on these kinases. Kinases are enzymes that shift phosphate groups around on proteins, and the activity of proteins is often determined by its phosphorylation state. So putting phosphates on and off of proteins are what these do, and the proteins work in different ways, whether or not they're phosphorylated. You'll hear about the BTK or Bruton tyrosine kinase, the PI3 kinase delta isoform, and I'm not going to say much about the spleen tyrosine kinase. So these are intracytoplasmic targets for drugs. Not surprisingly, the things that target stuff on the outside are big, like antibodies. They don't get into cells. Or cellular therapies, they don't get into cells. The molecules that target these enzymes are small. They go right through the cell membrane into the cytoplasm to hit their targets. Then there's the nucleus. That's where the DNA is. This is the thing that is getting deeply sequenced nowadays and is being used to study where mutations exist, what genes are on and off in cancer patients, and someday will lead to a very personalized approach to cancer treatment. Okay, we will be able to see that a patient with hairy cell leukemia or malignant melanoma has the same genetic change, and we can target that regardless of the disease. This is where medicine is heading. Anyway, in a very non-specific way, but very important way, chemotherapy targets DNA. And this is what Dr. Rummel was talking about today. So what we'll talk about are how we target all these various properties of the B cell. We have, chimeric antigen receptor T cells, which can attack CD19 and ultimately kill cells that bear CD19. Bispecific T cell engaging antibodies called BiTEs that can do the same thing. We talk about therapeutic vaccination, where we take the unique aspects of this surface immunoglobulin, use it to train the immune system to kill cells that bear that marker. We'll talk about the kinase receptor inhibitors and how these drugs work. And Dr. Rummel told you much about that, and we won't say too much, but I'll briefly go through that. So, and these are just some of the targets. I had to limit this to 30 minutes, okay? All right, vaccine therapy, okay? This is the question. Are we there yet? And I'd like to believe almost, okay? So hang in there and get to understand this. So, you know, most of us, when we think of vaccines, the word vaccine and vaccination has very powerful connotations, okay? Probably next to penicillin or antibiotics, when one thinks of the process of vaccination, one thinks of all the good aspects of medicine and how medicine is impacted on the public health. Probably vaccination, you know, has had more to do with increasing the general health of the world than anything else that we've done in medicine. And it's largely through the application of preventive vaccines. Okay? These are vaccines like smallpox vaccine. We've eradicated smallpox, okay, by immunizing people, vaccinating them so that they have antibodies to that virus and won't get smallpox if they can encounter the virus. Similarly, we all get vaccinated against tetanus and diphtheria and measles and mumps and rubella, and all these diseases can be prevented by getting a preventive vaccine. But there's another way to use vaccines, okay? We don't know a priori that you're going to get lymphoma, and if you do, what your antibody on the surface of your lymphoma cells is going to look like. So we can't make a preventive vaccine. But we can do something that Louis Pasteur did in the 1880s. He treated someone with rabies with a rabies vaccine after the child was bitten by the dog early in the course of the illness to generate an immune response and ameliorate the course of the disease. That's called therapeutic vaccination. Everybody knows about preventive vaccination. I want to emphasize and make a distinction between therapeutic vaccination, vaccine for treatment, versus vaccine for disease prevention. When we talk about lymphoma vaccines, we're talking about therapeutic vaccines, okay? Now, everybody knows what these Y-shaped structures are, right? I mean, Rituxan looks like this in your mind's eye, and so does Zevalin and Bexar. They have radioisotopes on it, but so does every other antibody in your plasma, or antibody molecule, surface membrane immunoglobulin, that part of the B-cell receptor complex that's on the surface of your B lymphocytes, okay, has this general structure, okay? These two arms at the end of them have regions that bind to proteins that give the antibody its specificity. So you can have an antibody against smallpox virus because this region has a shape that binds to smallpox virus protein. That's what defines this antibody's function, its specificity. Okay? How the immune system generates this diversity of antibodies is fascinating, but we'd be here all afternoon, and I'd probably put you to sleep if we got onto that topic. So take it that this is different from immunoglobulin, from B-cell clone to B-cell clone, from your lymphoma cells as compared with your normal B lymphocytes, and this antigen binding region. And this region, we'll talk a little bit about, is called the isotype or heavy chain region. This also confers properties to the antibody. I'll mention this in passing later. They're not specific properties, they're properties of the class. So there's 5 classes, IgG, IgA, IgM, IgD, IgE, and those 5 classes have properties that are unique to the class. What's most important is that the surface immunoglobulins that we want to vaccinate against are generally IgM or IgG, 2 different classes. They both have the same antigen recognition sequence. In fact, IgMs can class switch to IgGs as cells mature and make slightly higher affinity receptors in the lymph node. And still have a lot of similarity, but the class of the antibody changes and its function changes, okay? The memory antibodies are usually IgG. These are what float around for years and years and years, give you immunologic memory, prevent reoccurrence of infectious diseases. IgMs are usually the first things that pop up, and then they get switched over to IgGs for the long term, and that's kind of what happens. Now, I forgot to mention why I showed this slide. This antigen binding region has a bunch of regions within it that can itself be used to immunize the immune system. We call things that you can use to create an immune response against, we call them antigens. Just a word for a protein that will provoke your immune system into making antibodies or a cellular immune response. It's called an antigen, okay? Antigens bind to the antigen binding region. The antigen binding region has structural features. It's a protein. It has a structure that we call idiotypes, or idiotypic regions, collectively called an idiotype, which are sufficiently unique that you could immunize an individual against them. Even though you make this region, your own body, it's kind of different. It's made to bind to foreign proteins. It's kind of very different from everything else in your body. So you can actually use it to provoke an immune response. And that's why this was initially used to make a therapeutic vaccine for lymphoma. Ron Levy was really the pioneer of this approach. This is an example of an idiotype vaccine. It's an idiotype KLH protein vaccine, which is this is the vaccine approach that has been most studied, that has resulted in a number of phase 3 clinical trials that I'll talk about. And that includes the surface membrane antibody, the entire antibody from the tumor cell, if you're using one approach to generate this vaccine. It's called the heterohybridoma approach. That antibody will have these idiotypic regions that can themselves serve as antigens, and it's hooked to a mollusk protein called cheolymphid hemocyanin that's very foreign, really aggravates the immune system, gets it worked up, okay, and mixed with a little bit of GM-CSF and all injected together, it can provoke an immune response not only to the KLH, but it spills over to the idiotypic domains that are part of the immune response provoking complex. Okay, now in the approach that we worked with, this was generated by taking the lymphoma cells from a biopsy, fusing it to a cell line, and collecting antibody from the cell line that matched exactly the antibody that was on the surface of the tumor cells. Two other approaches were to use recombinant DNA technology, where you took the genes that coded for the idiotypic region and you clone them into generic genes for IgG. It so happens that one used an insect cell line approach, another a mammalian cell line approach, but to make a recombinant vaccine. Everything else was the same. The idiotype matched the tumor, but they all had a generic IgG structure, and they all used KLH and GM-CSF. So these were the idiotype vaccines. And there were 3 studies. The BioVest used the heterohybridoma technique. That's where we take the patient's tumor cells, we make a single cell suspension, pushing it through a screen in some tissue culture medium, fusing it to a cell line, and the cell line just produces this antibody that's identical to the lymphoma surface antibody that could be used to make the vaccine I just showed you. In the genotope approach, the DNA was cut out that coded for the idiotypic regions and cloned and expressed in a cell line, so that you were making a vaccine against the idiotype, but everyone got an IgG vaccine. In the case of the heterohybridoma technique, if your cells made IgM, you got an IgM. If it made IgG, you got an IgG. You were excluded if it was IgA or other heavy type from the study. And there's only 1 or 2 patients that we saw that had that. Favril used an insect cell line and an insect virus, a baculovirus, to clone the DNA into there and make an IgG idiotype. So these three organizations performed phase 3 studies, okay, which are all published, except the genotope it's under review right now, but not yet in print. Basically, all 3 studies used the therapeutic vaccination approach in follicular lymphoma patients that received an induction treatment, some form of treatment prior to vaccination, and then vaccination after treatment. Well, they were different in that the BioVest or the heterohybridoma technique and the genotype technique took patients that had never before been treated, and the Favreau trial, the insect cell line trial, picked patients that were untreated or that had prior therapies and had recurrences as eligible for treatment. They used different treatments. The heterohybridoma approach used a very aggressive 4-drug chemotherapy combination, and this is that was aimed at getting patients into complete response, because the objective of this study was to vaccinate only those patients that were in complete response. We believe that they would be the patients that would benefit most from vaccination, those with minimal residual disease, because as I'll mention later, lymphoma itself causes immunosuppression. Lymphoma cells, when they come in contact with other immune system cells, turn them off, okay? These other 2 trials used alternative approaches and didn't necessarily restrict vaccination to people that had complete responses. So patients that had partial or less responses could receive the vaccine. Okay, so I think that's a fundamental difference here, actually. And in fact, they all looked at survival endpoints, disease-free or progression-free or time to disease progression, all more or less mean the same thing. And the only one that showed any statistically significant difference, and these numbers come from our first analysis, it's actually about 0.027, since we got additional data now that we didn't have at the time that we wrote the paper. This showed a benefit, 14-month benefit in disease-free survival for patients that received the vaccine while they were in complete remission following chemotherapy. There was no statistically significant difference in the other 2 trials for vaccinated versus control patients. And I might add that the control arm in all 3 of these studies used an active immunotherapy, GM-CSF plus the keyhole limpet hemocyanin, the mollusk protein that I told you. So it was truly a blinded all 3 of these were blinded studies. This is the only Kaplan-Meier curve that shows at a median follow-up of 56 months, the disease-free survival was 42 months for the vaccinated patients, shown in the red, versus 30 months for the patients that got a control vaccine. And this was statistically significantly different. Vaccination happened in general between 6 and 12 months after chemotherapy. That was a period that was used to allow the immune system to reconstitute, because drugs that kill lymphoma cells kill normal lymphocytes as well. It's a side effect. And also gave us time to make the vaccine. If your disease came back prior to vaccination, you weren't vaccinated, because we believe and still believe, and the evidence supports that lymphoma causes immunosuppression. This technique relies on having a degree of immune competence to generate immune response. Studies in phase 2 of this product showed that, in fact, people make antibodies against idiotype after this vaccine, and patients also make T lymphocytes. We're going to talk about that in a bit, that kill lymphoma cells following this vaccine. So there's scientific evidence that it worked, and this is clinical evidence suggesting a benefit. Now, these surface membrane immunoglobulins, these antibodies on the surface of the cancer cells, told you they could be one of a couple classes. IgM and IgG in our study were about 50-50. About half the patients had IgG isotypes, half had IgM isotypes. And in a retrospective look, this was not prospectively part of the trial, we looked back to see if patients had different outcomes depending on the class of their immunoglobulin. Remember, the other 2 companies with negative studies turned everybody's antigen into an IgG. We left you with what you had, okay? And in fact, what was found was that the IgM patients were the ones that had all the benefit. There wasn't a statistically significant improvement in progression-free survival for patients that had IgG vaccine. In fact, we did the same analysis. This is all the controls pooled, and it shows the p-value of 0.01 for IgM and 0.3 for IgG. Difference. But if we compared patients that were IgM controls that got the control vaccine, that is, their tumors were IgM, with those that were IgM that got IgM vaccine, or IgG vaccinated patients against IgG patients that got controls, the same thing held up. No matter how you looked at it, all the benefit was in the IgM group. And in fact, if we had done the trial only with IgMs, we would have had a p-value that would have been good enough to get a one-study approval for an indication. But this is retrospective, okay? It has to be, these kinds of things have to be done prospectively to get approval and also to prevent investigator bias. You look long enough at data, you start to see all kinds of things, okay? In any event, it turns out, the story is interesting. IgGs actually, I told you they're the memory antibody, okay? It's what your body makes second. And it's because they're actually somewhat immunosuppressive. The body's protecting itself from making antibodies against those foreign, semi-foreign idiotypes because IgG has regions in its heavy chain of the heavy chain portion of the molecule that turns off an immune response. That's why we use IV gamma globulin to treat autoimmune diseases and things like that. It stimulates a suppressive T cell called regulatory T cells. So it may be that by using an IgG, you're kind of shooting yourself in the foot when you're trying to provoke an immune response. Okay? Again, that's hypothetical, but the data are as they are. All right, moving on. Okay, so one way to provoke an immune response is to stimulate it with a foreign fish protein, GM-CSF, and the tumor antigen. Another thing you can do is unleash the immunosuppression that lymphoma causes. Okay, so we and others have data that this drug, lenalidomide, actually reduces immunosuppression. In the laboratory, if you mix this drug with normal lymphocytes from lymphoma patients, they suddenly can form immunosynapses, something they can't do without this treatment. This turns around immunosuppression. And there's a number of mechanisms by which it does that. So we thought that this would make an excellent adjuvant for an immunologic approach. And everyone knows about Rituxan and how wonderful it is. So we thought maybe some patients don't respond to Rituxan because they're immunosuppressed. And if we use this drug first to reverse immunosuppression and retreat them, we'll get a great response. So that was some thinking that went on to lead us to design this trial where these patients were all resistant to rituximab, defined as failure to respond or progression of their lymphoma within 6 months of receiving Rituxan, okay, or a chemo-Rituxan regimen. So these were people that didn't respond to Rituxan. You couldn't get on this trial unless Rituxan didn't work. And most of these patients had follicular lymphoma. There were a couple mantle cells and others. I'll show you the distribution. We gave 2 months we did a lot of biologic studies. This is how we're learning about how this drug works on the immune system. And actually have stayed tuned to what's going on. We'll present some data at ASH this year. We have a biomarker for response to this drug from this study. We treated patients with lenalidomide for 2 months, 2 28-day cycles. In medicine, a month is 28 days, okay? There was a subset that got a low-dose dex with or without, but it's not important for the purposes of this presentation. Basically, 2 months of this, and then patients, regardless of whether their tumors were growing or not growing, or responding or not responding, and I'll show you the results, got Rituxan again, okay? During the 3rd month, and then they just stayed on this afterwards, okay? So it's sort of like a priming with lenalidomide. What we saw was some patients, the lenalidomide itself put them into remission. This is 40 patients that were in this study. So there were 14 patients that had responded, either complete or partial. Overall response rate was 35%. After giving the Rituxan, the overall response rate went up to 63%, and this shows you what happened. Patients that were in CR stayed in CR. Patients in partial response went on to CRs. Patients with stable disease, for the most part, patients upgraded their response during the Rituxan. And it was really kind of dramatic and kind of immediate. During the first week, those patients that had palpable lymph nodes, they would shrink after having been on the drug for 2 months. So in those cases, we believe that it really was the interaction of the 2 drugs, and I'll show you more data about that in a minute. This just I was wrong, there was 2 Kaplan-Meier curves. I apologize, I didn't know that this was on the slide. This just shows progression-free survival. So patients that got 1 single 4-week course of Rituxan, who were resistant to Rituxan, on average, that's the median, progression-free survival was 19 months. Okay, and the follow-up was 20 months, greater than the median, so you know it's a true median. Okay, and now if you have Rituxan and respond and relapse and get retreated, The duration of response is about a year. So this is actually even better than that. And this is in Rituxan refractory patients. And survival was very good because patients stayed on therapy that were responding indefinitely. And there's other good treatments, as you'll see, that patients could go on to if they progressed after this treatment. So we've presented this last year at ASH and are getting set to publish it. And then suddenly adrenaline. This May, when John Leonard shows data from CALGB, they did something just like we did. And these guys, they work fast. They're going to bury us, you know. And I knew that they were doing this, but I never thought a cooperative group could pull it off as fast as a single institution. These guys are good. So, anyway, but look what they did. You had to be Rituxan sensitive to get onto their study. These were all relapsed patients, but thank God they designed it differently than us. So even if we don't get this damn paper done before them, we'll still have something to say, okay? And they randomized patients to either lenalidomide alone or Rituxan and lenalidomide, okay? And what they reported was that the median event-free survival for the patients that got the combination was like ours. So now you got two people giving about the same results, but ours are in Rituxan-resistant patients, theirs are in Rituxan-sensitive patients. And like our study, the event-free survival was improved when they added Rituxan to lenalidomide, and the response rate went from 51% to 73%. Not much different than our data. So maybe there's some truth here, Anyway, I was happy to see that. Everybody has the structure memorized after Dr. Rummel's unforgettable speech this morning, and it's a remarkable drug, and it is new, okay? We've been using it for several years, and it's changed our upfront approach, despite the lack of a label in this country for first-line therapy, okay? We oncologists frequently do things outside the label, okay? And basically, this shows his data. Excellent overall response rate in a phase 2 trial by Brad Cal, and in upfront setting compared to R-CHOP, R plus Benda gave not only a better response rate, but a better safety profile. You have the much better slides than this from Matthias Rummel. All right, let's move on to some more of the new stuff, okay? And this is what I think is representative of the new stuff. There's a lot of things going on, but particularly exciting are these molecules. These are a little harder to memorize than bendamustine, but these are the B-cell receptor kinase inhibitors. Remember I said the B-cell receptor is the immunoglobulin on the surface and some proteins inside that are hooked to that sort of get turned on by that receptor when it's engaged by antigen. Or, as we learned the day before yesterday, there was a paper in Nature that came out showing that in CLL, the B-cell receptor stimulates itself. There's not some antigen there. There's some unique determinants on this immunoglobulin CLL that makes it constitutively on. It's an on switch that's sort of stuck. Anyway, moving on, Ibrutinib, as a name, it used to be PCI 32765, and then CAL101, which is now GS1101. It doesn't matter, they both inhibit some of those signaling proteins. I'll show you in a minute how they work, okay? Like I said, if you look at things too long, you start to see lots of things, okay? And you stare at these things and you see lots of spots, colored spots. But anyway, BTK and PI3K delta, okay? These are two molecules downstream of the B-cell receptor that get turned on when the receptor's turned on, or in the case of CLL, when the receptor's turning itself on. Think about that. And actually phosphorylates downstream systems that actually go and turn on families of genes which actually control all of cell metabolism, glycolysis, et cetera, all kinds of things happen to cells when this is engaged and these things get turned on, okay? Now, PI3 kinase is in every single cell of the body, but different isoforms. Delta is only in the hematopoietic cells. So GS1101 was designed to inhibit this. The BTK is unique to the B cells because, well, actually it's in other hematopoietic cells too to some extent. But it got its name from the immunodeficiency state that happens when you don't have this. In any event, or the person that described that, Bruton, there's molecules for these two things, and you would predict that they would work. And you would hope that they don't have a lot of side effects because they're B-cell specific. At least that's what I would. And in fact,
and they're pills.
And they're pills. One you take once a day, the other you take twice a day. So CAL101 or GS1101 is a pill you take twice a day, and BTK you take once a day, okay? And it's not per meter squared dosing. It's like Tylenol. One size kind of fits all. They did phase 1 dose response studies and found out within a certain range it made no difference. You saturated all the receptor sites, and it's so easy to do. They took peripheral blood and they looked at the normal cells and they saw how much of the receptors were full, and they came up with the dose. Anyway, follicular lymphoma, in this study, you'll see, this was Lugano presentation, and I thank Chris Flowers for the slide. The 16 patients, 38% overall response rate, and 46% was the overall response rate for evaluable patients. This was intent to treat, 38 and 46 rather, yeah. So these were all patients with recurrent disease. What's interesting, the other group that was well studied here is CLL, and look at these response rates, even better. CLL is a disease where that receptor is turned on constitutively. It was the most beautiful paper, the 13th in Nature, 13th of this month. Follicular lymphoma may be turned on by antigens we don't know about, okay? Just speculating here. This drug works best in mantle cell lymphoma, in CLL, and in follicular lymphoma, okay? The side effects are pretty negligible relative to what we do in oncology. This PI3 kinase GS1101 is very active in the same diseases that I just showed you. This shows some data for indolent lymphomas, 59 patients. These are lymph node measurements in patients that are on the drug, and you could see this is negative part of the scale, positive. Most patients had progressive reduction over in their lymph nodes. Each line is an individual patient that was responded. So, and they're lined up by progressively better response. So some patients had 100%, that's a complete response, okay? Some patients had 50% and better, that's a partial response. And patients had less than 50%, but some shrinkage, that's called stable disease. But stable disease is a benefit. These patients are taking a pill and they're asymptomatic, and it looks like these responses are ongoing. It's very kind of durable if you stay on the pill. We know how antibodies act. I told you about the constant regions that recruit the immune system cells and complement to kill tumor cells. Now I'm going to focus in the remaining minutes on cytotoxic T cells, okay? So like antibodies that are very specific, your immune system has cells that are very specific. They're very specific in their targets, and they can target viral antigens that are expressed on virally infected cells, or they can target organs if I try to do an organ transplantation on you, foreign tissues. They can also target tumors, and are the reasons that some patients have spontaneous remissions, and there's lots of mouse models showing that you can cure cancer by getting these cells, these cytotoxic T cells or CD8 T cells, to turn on against the cancer cell. In the body, it's kind of a complex process, and it's got to be complex, or these cells could go wild and start hurting you, and you get autoimmune diseases. You have to have antigen-presenting cells that present tumor antigens from dead tumor cells. They scavenge them up, and they show them to these naive or resting, CD8 T cells. They show them in a certain way that turns them on. There's co-stimulatory pathways that have to be present. And interestingly, those co-stimulatory pathways are missing in some cancer patients. It's part of the reason an immune response doesn't get generated against cancer. In fact, there's other ways that cancer makes the immune system paralyzed. And another way is it can interact with these T cells and make them unable to form this immunosynapse that leads to death of the cancer cell. In any event, if you present the tumor antigen properly, these CD8 T cells will kill tumor cells really well. And actually, that was what was so attractive with the vaccine, is that it's been demonstrated now in more than one lab and on more than one occasion that you generate idiotype specific cytotoxic T cells with the therapeutic vaccine that we discussed earlier. Okay? Well, what can we do with T cells that get paralyzed by tumor? or in a patient without a lot of T cells because of prior lymphodepleting chemotherapy, we can take what T cells they have in the lab and stick in them a chimeric antigen receptor. What that is, it's a receptor on the surface that looks a little bit like the antibody molecule, but it's the T cell receptor, not the B cell receptor, because it's on T cells. Structurally, there are some similarities, not identical. And you basically get this into the cells by putting a viral vector into them that infects them and makes them put a receptor on the surface. In this case, what was done here is the chimeric receptor was against CD19, that antigen I showed you at the beginning. So you took a patient's T cells, you transfected it with a viral vector that made the cells express a T cell receptor specific for CD19, okay? And this chimeric receptor had some on switches that were hooked on the inside of the cell. So it didn't need the co-stimulation that you needed in the normal situation. I told you in the normal situation, there has to be co-stimulatory things that happen. It's complex. Well, that's because this receptor needs stimulation from alternative pathways. This receptor on the CAR T cell is on. And the cells go crazy when they hit cells that have their antigens on them and proliferate. And actually, this patient had CAR-19 therapy for CLL, and you could see the lymphocytes disappeared as well as the bone marrow became negative. So this is very preliminary stuff, and just a few patients have been treated. But theoretically, you could make chimeric antigen receptor T cells for anything, CD19, CD20, pancreatic cancer antigens, prostate cancer antigens, anything. This is the beginning of cellular immunotherapy. Now, that's expensive, and the labs, you have to use these lentiviral vectors. They're like AIDS type of viruses, and costs a fortune, and it's complex, and there's some cytokine release issues, and there's lots and lots of things to talk about. But what if you could do it in an easy way? Pull something off the shelf for everybody, not have to take their own T cells and infect them and grow them and give them back, but just to take something like Rituxan off the shelf and give it to somebody, but have it work the way that chimeric antigen receptor T cell works. Well, these BiTEs, or bispecific T-engaging antibodies, are antibody derivatives. They're not really antibodies. They're just two antigen binding regions, single chain antigen binding regions bound together, and they took a T cell antibody, anti-CD3, and an anti-CD19 antibody, bound them together to make blinatumomab, which will bring the cytotoxic T cells into your CD19 tumor cells and kill them. Now, this is fascinating because the CD3 antibody that made binds to a region of the T cell receptor complex, an invariant region, and turns it on. So you don't need any co-stimulation from other molecules. It's like the CAR-19 cells. It's on. So you can imagine these T cells circulating around. They're bound by this antibody. They're turned on looking for something that has CD19, and when they bind them, they kill them the way a cytotoxic T cell does. So it's a new approach. This drug is in a pivotal trial for acute lymphoblastic leukemia, the common leukemia in children. And there's been some phase 1 data in lymphoma, B-cell indolent lymphomas and aggressive lymphomas. I think it's a very exciting approach. It's amazing that it works. So we talked about vaccinate, all these immunologic approaches, vaccination, unleashing the immune system by reducing immunosuppression via immunomodulatory drugs. We talked about kinase inhibitors and how they can be used, how you can change monoclonal antibodies around, how you can change T cells around to fight lymphoma. These are all novel approaches. Where they'll end up, is anybody's guess, but I think they're going to be here for development and part of what we do. And I think really each of these represent, a paradigm. And this emerging paradigm, I think, is kind of the end of the beginning of immunology applied to cancer, okay? And we're now going to get into the next phase of just further refining and using these approaches to target the immune system against cancer. There are other things that we're just beginning, but this is immunology, I think, the pathways that are going to be taken in the next few years. Thanks for listening.
It's exciting, isn't it? I know that some of this was complex and difficult to follow, but I think the bottom line is we are getting to the point where we are getting our own immune system to actually kill the cancer cell in your own body. And some of that may be done with pills, not with hours and hours of infusion chemotherapy. So any questions for Dr. Schuster? We're a little over time, but we'll have our panel discussion and end on time. Any specific questions? Yes, please.
I know it's hard to predict, but
Use the microphone, please. Thank you.
I know it's hard to predict, but what is your best guess before this gets to be something that is approved for use?
Oh, I mean, we'll have the kinase inhibitors probably on the market in 2014. Okay, we're doing experiments in the lab right now to make sure they don't interfere with chimeric antigen receptor T cells in the lab, because we're already planning to combine those approaches together.
Okay, I'd like to ask all of our speakers who are still present to please